actually know Justine. My name is Susan.
Okay, welcome back. In this set of video lectures, we're going to talk about the medical record. When you think about the medical record, the important thing to realize is that in addition to providing a record of patient care, it also serves as a legal document. So that gets into why we need consents and some other things. And again, as we talked about, the medical record is a record that's created for each patient at their first medical office visit. It's used for planning, evaluating, and coordinating care, whether it's in the inpatient setting, outpatient setting, between facilities. And medical record employees are responsible for safeguarding the security of the medical record and maintaining confidentiality. The medical record administrator is responsible for ensuring that all the diagnostic tests, labs, radiology, and everything else are in the medical record. In the paper world, that means managing file clerks to make sure that the reports get filed in. An electronic version, it's make sure that the test results are uploaded correctly. The medical record administrator is also responsible for making sure the medical record is complete and that we have dates, signatures, and all other legal requirements, and needs to be kept in one place to ensure integrity of the medical record. Medical record administrator is responsible for receiving and distributing faxes that need to go in the medical record. This could be outside labs because not all labs are equal. They can't do all tests. So sometimes they go out, they need to come back, all these different types of things. Once the physician has reviewed said labs or other diagnostic tests, they're responsible for the information reviewed. So in an old days, we'd get a paper lab, we'd clip it to a provider's door, and then they'd initial that they reviewed it. Now, of course, this is all done electronically. It goes into their inbox, they see it, and once they've seen it, it's journaled. And of course, we have HIPAA, our favorite law of all time, covers data security, improper release, standard data sets. So we need to be HIPAA compliant. And again, there's specific parameters regarding consent. It talks about the notice of privacy practices, which everybody's familiar with. You've been seen in a physician's office. The consent indicates that the patient has the right to review the notice before signing it, and so on. So a lot of medical record content is dealing with consents, both for treatment and for payment, which we'll get into. And again, sometimes we have other legal permission or state law requirements specific to certain things. And the consent must state that the patient has the right to request restrictions on the use and disclosure of this, right? And covered entities, you talk about this in the legal class. Covered entities are basically anybody who gets electronic information. And of course, when we have consent, consents have to be authenticated, have a date, and so on. If we don't have that, it's not a valid consent. At the bare minimum, medical records in an outpatient setting have to have patient identification, assignments of benefits and release of information, which allows us to release information to payers, consent for treatment, Medicare lifetime claim if they're a Medicare patient, the patient's medical history, including any drug allergies, medication list, and problem list, right? In addition, we also need to have a waiver of Medicare liability if they're Medicare patients. If they're going to have a procedure done in the office, scope, or what have you, there needs to be consent for that. Physical exams, any orders for tests, clinical observations, lab reports, and records of any procedures, be it something that is a minor procedure, something that is somewhat invasive like a colonoscopy, or something more than that. All these procedures need to be mentioned in the medical record, right? We also cover PrevMed services in the primary care setting and immunization records. Now we get into the fun things. Uniformity of medical records. With so many electronic health records, they all vary a little bit, but some key core elements still remain. They need to have dates. They need to be authenticated, right? And there needs to be a title. We want to know whether it's a medical assistant entering vital information, whether it's a physician, nurse practitioner, and so on. Patient registration, key component for compliant billing. Can't tell you the number of facilities and medical offices when they have duplicate patient numbers, one encounter or patient care episodes billed to an invalid number, facility or medical office doesn't get paid. So we have to make sure that we update this registration form frequently. In fact, it's very common that this is updated at every encounter. And financial responsibility. So in other words, who's going to accept responsibility if the insurance carrier does not pay, right? So let's say the insurance company delays payment, doesn't pay for whatever reason, patient loses their job. Who's going to be financially responsible? This agreement and assignment of benefits authorizes the medical office to file an insurance claim and accept payments. So without the assignment of benefits, the medical office doesn't get paid. Consents, of course, legally, we have to do a consent for treatment unless the patient's being seen in the emergency room and is unable to consent. So we have to have a consent for treatment. Has to be done by somebody who legally can consent for treatment. In other words, a competent adult. Pretty straightforward stuff here. And then, of course, with Medicare, we have the lifetime beneficiary claim authorization. This allows the provider to file claims on behalf of the patient to Medicare, right? So you don't have to go back to the patient and they file it, right? And of course, these can be updated, or a patient can sign a lifetime beneficiary claim authorization. We talked about the patient's medical and interval history, right? Past medical history, family history, social history, right? And the patient medical history form, many times it doesn't change, frequently it does, and it gets updated. Again, should have a complete past medical history, both personal, family, and what have you, right? A lot of interest in terms of treating women for breast cancer now. That gets into what first degree relative has breast cancer, very important point. Again, medication list, the problem list. This poses problems with electronic health records. Sometimes providers will just drag the problem list into a progress note. In some systems, you can do that technically. Not always a good idea, because sometimes these problems get resolved, right? Just like the medication list, if you just drag it into a note, current meds, and you're not reviewing it, yeah, you have the content. It's not necessarily valid content. Anything that affects the patient's ability to understand instructions, the ability to read, language barriers, cultural beliefs, religious beliefs, things like that should be noted. Some religions, for instance, don't believe in blood transfusions. This is going to be a problem if you have somebody undergoing cardiac bypass surgery. And again, sometimes it's necessary for a practitioner to discharge a patient from care. In other words, you're no longer participating in a PPO. The patient's moving, changing insurance companies, the physician's retiring. There needs to be some sort of documentation, typically in a letter that's in the patient's chart. Advanced beneficiary notices, you can kind of think of these in terms of consents, except they're dealing with Medicare for payment, right? Has to be signed by the patient before any services are rendered. And an ABN is tailored specific to each organization. At the bare minimum, they need to have the name of the service or procedure, a statement that specifically states that Medicare does not pay for the service, statement that the patient agrees to accept financial responsibility. Some patients believe that Medicare is an entitlement and covers everything. I think we know better in terms of that. And again, the signatures that we've talked about and acceptable notification standards, which include being written in lay language and specifies which items or services payment is going to be denied for, will or will not be denied. Specify the reason the provider believes the Medicare payment will likely be denied, and be delivered by a qualified notifier to the beneficiary or the beneficiary's authorized representative before any services are provided. And then be received and comprehended, in other words, understood by either the beneficiary or the beneficiary's responsible authorized representative. And that's all I have for you. Come back and we'll talk about record retention. We'll talk about HIPAA and some other topics related to the medical record. We'll see you then.